Good Thursday morning. This is Dr. McDaniel at GYN Corner. Yesterday I had that wisdom tooth pulled out. It had a cavity in it, so I'm still in pain. So I'm speaking a little bit funny. It's a little bit hard to talk. So this will probably be a short presentation. As I mentioned yesterday, I received a viewer question about preterm delivery. A lady whose daughter had 3 preterm labor and deliveries and lost all 3 pregnancies. She didn't say how far along the pregnancy was, so that has a huge impact on survival rate. But I'll speak for the next couple of days, at least today and tomorrow, on preterm labor and preterm delivery. Because of that wisdom tooth extraction, I will be sipping water quite a bit. So preterm labor and preterm delivery is the topic for today. Preterm delivery is considered any pregnancy under 37 weeks. Full term is between 37 and 42 weeks, and the shoot for date or the expected date for delivery, or what we call the estimated or expected date for confinement, is 40 weeks. So 3 weeks before the due date up to 2 weeks afterwards is considered full term, perfectly healthy, normal. There shouldn't be any issues. Under 37 weeks is preterm. Now, we divvy preterm into certain categories. So a late preterm is between 34 and 37 weeks, or 36 weeks and 6 days. Early preterm is between 32 weeks and 34, or 28 weeks and 34 weeks. And extremely preterm is under 28 weeks. Now, pretty much all babies born in America at 32 weeks and older, even though they're preterm, they should survive and they should do really well. Between 28 and 32 weeks, it depends on the care that was given preterm and then the care that's given immediately upon delivery. Under 28 weeks is highly variable. Now, to give perspective, in most states, one can have an abortion up to 25 and a half weeks, because 25 and a half weeks and under is considered non-viable. So 28 weeks is considered viable, but it depends on what's done as to how well that child survives and the quality of life. But as you can see, under 28 weeks becomes a little murky, because 2 weeks earlier, that woman could have an abortion, no problems in most states, including New York State. So I'll speak on, and also to give some background, worldwide, there's over 15 million preterm deliveries, and that's about an 11% rate of preterm deliveries around the world. In America, the rate's around 15%, so between 13 and 16% on average, so around 15% preterm labor, preterm delivery rate. A lot of women can have preterm labor, but depending on the circumstances, they'll still make it to full term. Now, we always like to give the background on the setting and who we should be concerned about as to whether their risk of preterm delivery is imminent. There are a lot of factors which I'll go over. The biggest factor is we don't know who's going to be at risk. So the largest factor is no risk factor at all, especially for the first pregnancy. So as far as factors or risk factors for preterm labor, preterm delivery, the largest one is someone who's already had a preterm delivery. That's the largest factor. Majority of women have preterm deliveries If they've had more than one pregnancy, they've had previous preterm deliveries. And unfortunately, the age at which that preterm delivery occurs becomes earlier and earlier with subsequent pregnancies. Another risk factor is cervical incompetence or cervical insufficiency. And that's where the cervix is compromised. Either the tissue makeup, so the connective tissue, the musculature in the cervix itself is compromised, weak. That could be genetically, such as women with Marfan syndrome, or women whose mothers received diethyl steroid, which is DES. Most women who have that DES syndrome will be either very, very late 40s to 50s or older, because that medication was taken off the market years ago, but women were given DES for nausea, vomiting of pregnancy. So that changes the tissue makeup. Poor cervical strength is what it is. Cervical incompetence or cervical insufficiency can also occur for women who have had multiple surgeries. So multiple DNCs or dilatation curettage, where we stretch open the cervix in order to clean out the uterus. Multiple DNCs can potentially weaken the cervical ring or the internal os, which is predominantly responsible for holding the cervix closed. Also, any woman who's had surgery for severe precancer of the cervix, so a cone biopsy, a LEEP biopsy, loop electrode excision process, so where we had to remove, physically, surgically remove a large chunk of the cervix because it has severe precancerous changes in it. So cervical incompetency or cervical insufficiency is a risk factor for preterm labor, preterm delivery. Women who are born with genetic dispositions towards a weakened cervix, or women who have had surgeries and put themselves in a position where the cervix is compromised. Uterine anomalies can also increase the risk of preterm labor and preterm delivery. Anomalies where when that woman was in her mother's uterus, the uterus did not develop properly. So everyone starts off with two uteri. We call that uterine horns. So everyone starts off with two tubes of the uterus, and as those tubes build up, they come together and they merge to form one. But everyone starts off with two, and that middle tissue is disintegrates somewhere around 20 when that woman in her mother was around 20 weeks or so. That tissue in the middle dissolves and breaks up so that we all get one uterus, but we all start off with two uteri. Some women never merge, so they are born, and of course the rest of their life they have two uteri. Sometimes there's one horn, one side of the uterus, we call each a horn. So one horn may not be developed at all. So they pretty much have half the size of a uterus. It's very small. Both horns can potentially be developed, or they can merge and then not fully merge. So you'll have a heart-shaped uterus where the bottom of the uterus looks normal, but it's heart-shaped on the top because the upper portion never merged together. We call that two horns, where you have two separate uteri, but each uterus is half the size of a normal uterus. We call that a uterine didelphys. And where it starts to merge, but it doesn't merge all together, it's a septate uterus. If it merges all together, but there's still a wall, it's still a septated uterus. If they have a rudimentary horn that doesn't form, then they just have a unicornate uterus. And those anomalies compromise the uterus because the uterus is not as large, and the response of it to a growing pregnancy is going to be abnormal. So if someone has a septum, or they have just a single horn, they're at a high risk for preterm labor and preterm delivery, because that small uterus cannot accommodate that pregnancy if it's a single pregnancy, and it certainly can't accommodate a twin pregnancy. So fetal uterine anomalies, so cervical problems, uterine anomalies. Infection can also do it. Infection is a high risk factor for preterm labor and delivery if it goes unaware. So a bladder infection that turns into a kidney infection, or a vaginal infection that for whatever reason ascends into the cervix, into the uterus. Any infection in the uterus can potentially compromise the pregnancy, because that infection causes inflammation, and inflammation causes uterine contractions, and if the contractions persist and are allowed to continue, that can cause uterine delivery. Preterm delivery. So let's see, we have also multiple gestation, so IVF, or reproductive fertility help, that causes, for the most part, until recently, most women would have 2 or 3 gestation pregnancies, so they'd have twins or triplets. Twins and triplets increase the size that the uterus has to carry, so the uterus can't accommodate such a large size for very long, and it starts to eject the pregnancy. It starts to contract preterm delivery. So most people are aware that if they have twins or they have triplets, they will have preterm labor and preterm delivery. Certain illnesses can potentially cause preterm labor, preterm delivery. Someone with kidney problems, or they have chronic infection, inflammatory issues, can potentially be at an increased risk for preterm labor. Sometimes diabetic mothers, and that's kind of a 6 degrees of separation. So if someone has diabetes, sometimes they will have abnormally large babies, or an abnormal increase in the amount of fluid around the baby. So again, it stretches out the uterus, too much preterm labor. The increased fluid is called polyhydramnios. That can occur out of the blue also. So we monitor all women to see if their uterus is appropriately enlarging with the pregnancy. And then nondescript factors such as poor nutrition, poor health, can increase the risk of preterm labor, preterm delivery, and illegal drug use, cocaine, can increase preterm labor, preterm delivery, because it specifically increases the risk of uterine contractions, and those contractions, of course, can cause preterm labor, preterm delivery if they're not addressed. I think those are the big ones. But as I stated earlier, the largest risk factor is an unknown risk factor. So over 50% of women with their first pregnancy who end up having preterm labor and preterm delivery, we won't have any reason to suspect that they're at a risk for that and that they're going to have a preterm delivery. It's out the blue with no obvious risk factors. So, as I said, sorry, I had this wisdom tooth was pulled. It's a little bit swollen now yesterday, so it's difficult to talk. We have limited office hours today. I think I'm seeing 8 patients. It's hard to talk. It's very painful. I hope that's been helpful as an introduction to preterm labor, preterm delivery, and then tomorrow I'll continue the preterm labor, preterm delivery theme. I'll go into ways to not manage, but ways to monitor and to screen women to see if they are at risk or if they're on the path towards preterm labor, preterm delivery. This is Dr. McDaniel at GYN Corner. Thank you for watching. Have a great rest of the day, and I'll be back tomorrow.